Hi everyone, welcome back to yet another session of overview of exam case discussions. So in this series, we have had one discussion already, an overview that had given on hypoglycemia in pregnancy. It had both over diabetes and gestational diabetes mellitus. So today, I am going to be talking about a second case discussion, and that is fetal growth restriction. Now we have also had a discussion on antepartum hemorrhage, and the video on that will come after 2 days. But for now, today, this is a discussion on the topic that Dr. Jayatra had presented on a Google Meets live session. It was an excellent discussion of an hour and a half, in which we had covered all aspects of fetal growth restriction and its management. So this lecture is going to be an encapsulation, a concise form of it. I do believe that if you are going to watch this lecture, you all can watch it in 1.5 or 2x so that you all can even speed up this discussion and get done with it quicker. So let's begin. So the first thing that comes to my mind when I talk of fetal growth restriction is obviously going to be the definition. What is fetal growth restriction? By the way, fetal growth restriction is the newer term for what we called earlier as IUGR, that was intrauterine growth restriction. Intrauterine growth restriction was even earlier called as intrauterine growth retardation, but retardation was implying a meaning of the baby being mentally retarded, which was a bit offensive for a lot of parents, which is why we shifted to IUGR and now we have shifted completely to fetal growth restriction. So the definition says that whenever a fetal weight is less than 10 centile or 10 percentile, that is when we say that the fetus has growth restriction. Now, what is percentile? You all would know that the 10%, the lowest 10% of population, if I'm stratifying the population on the basis of their effective fetal weight, then the bottom 10% are the ones who are going to be called as the ones who have fetal growth restriction. Similarly, for the ones who have the weights at more than 90 or even 95 percentile, those are the ones that we will call to be having large for gestational age or macrosomia. So when I come to FGR, there are a few ways in which I would like to classify it. So the first classification is going to be on the basis of when does the insulting factor come in between or when does it intervene. So on the basis of that, I have early onset and I have late onset. Early onset is something that I also call as a symmetrical FGR, whereas the late onset is what I also call as the asymmetrical FGR. Now, what is this symmetry about? What are the diameters or what are the circumferences that we are talking about? What has to be symmetrical for me to be able to make this classification? So, basic concept before I proceed there. Now, until a baby is, or let us first make three columns. One is fetuses that are below 32 weeks of gestation. The next one is for babies at more than 32 weeks of gestation. And next and the last category is going to be for the ones who are more than 34 weeks of gestation. So for the ones who are at less than 32 weeks of gestation, in them, if I'm going to be looking at the baby's abdominal circumference and the head circumference, then the head circumference is more than the abdominal circumference. Whereas at the other extreme of it, that is after 34 weeks, the abdominal circumference crosses the head circumference. And remember, I am not saying diameter. Remember, I am not saying diameter, I am saying circumference. Circumference is a line that I am drawing over the entire head or over the entire abdomen. You would ask me, where do we measure it? Just for your knowledge sake, it is basically head circumference is taken at the level of basal ganglia, at the level where both the thalami are seen equally, whereas abdominal circumference is taken at the level of ductus venosus joining the IVC. Whereas after 34 weeks, it is head circumference is less than abdominal circumference. Whereas in this period in between, the gray zone, here the head circumference is equal to the abdominal circumference. Now the significance of this is in several topics, but especially in breech presentation. In breech presentation, whenever a baby is delivering by breech presentation, we often say that a preterm breech is an indication for cesarean section. The reason is, in preterm babies, especially the ones who are below 32 weeks of gestation, the head circumference is more than the abdominal circumference. So when the baby is coming down, the abdomen will not dilate the cervix completely, and unfortunately the fetal head, which is much bigger than the abdominal circumference, will get entrapped at the level of cervix. Along with that entrapment, there is also the umbilical cord that is going from its abdomen to the placenta above, which gets trapped or which gets compressed between the fetal head and the under dilated cervix, that is the not fully dilated cervix, and that will lead to asphyxia and fetal death at that point itself. So that is the reason we often say that breech presentation should not be delivered, preterm breech presentation should not be delivered vaginally, especially the ones who are very preterm, that is below 32 weeks of gestation. So coming back, so one is early and one is late onset. So how do I define early and late? So roughly the ones that occur at less than 20 weeks are early, whereas the ones that occur after 20 weeks are late. So what are the factors that can affect a baby at less than 20 weeks? The first one is intrauterine infections, especially torch infections. So torch infections are an important cause of infection. Now are an important cause of symmetrical IUGR. Now why? Now during the first 20 weeks, there is formation of new cells, or what I also want to call as hyperplasia, that goes on. Whereas from 20 to 40 weeks of gestation, there is more of hypertrophy than hyperplasia. So basically in the first 20 weeks there is an increase in the number of cells, whereas in the next 20 weeks or the second half of pregnancy there is an increase in size of cells. So whenever there is something that affects the first 20 weeks, the total number of cells are going to be reduced. So whenever there is reduction in the total number of cells, that will lead to equal reduction in the head as well as in the abdomen. That leads to symmetrical FGR. So the reason this can happen is first of all torch infections, then genetic abnormalities, and by genetic abnormalities I intend to say genetic mutations or even chromosomal aneuploidies like Edwards syndrome, Patau syndrome, Down syndrome. So any of these, Turner syndrome, anything. You can also have congenital abnormalities. Then metabolic abnormalities like glycogen storage disorder. So metabolic disorders. So these are the major reasons why symmetrical FGR can occur, because these are all the things, if they can invade in the first trimester, they are going to affect the baby very badly. The total number of cells are going to be reduced. So the head circumference and the abdominal circumference both remains the same. Now coming to asymmetrical IUGR, but before I come to asymmetrical IUGR, there's one more concept that I would like to tell you all. Now imagine that I have reduced blood supply. I have reduced blood flow to my body. So that fetal body will decide कि now that I have limited amount of blood, I need to compartmentalize the more important organs and the less important organs. So that the more important organs receive more blood, or it receives all the blood in comparison to the less important organs, which can be salvaged later on. So which are those more important hormones or organs? The first one is obviously the brain, which we also call as the brain sparing effect. The next one is your heart, because it controls the pumping of the blood. And lastly, a surprising but something that should not really surprise you is your adrenal gland. Now adrenal gland Q, you all have read that the most important hormone in your body, it's an MCQ question, is mineralocorticoid or aldosterone. Similarly, the adrenal gland not only secretes mineralocorticoids, it also secretes a stress hormone, that is corticosteroid. That corticosteroid is also going to help in fetal lung maturation. Apart from that, it also is responsible for the secretion of catecholamines, the sympathetic hormones. So basically it secretes all the important, or rather the most important hormones that keep a person alive, which is why the body will try to salvage adrenal along with heart and brain as well. Whereas the organs that are compromised are going to be kidneys, the gut by that I mean the intestines, and lastly the liver, because it says कि I can sacrifice these organs for time being. Once the normal blood supply is restored, which is going to be after delivery,
At that point of time I will salvage these organs, but the other organs, if I'm going to not do enough to make them survive, to give them enough blood, I will die immediately. So I have to just pull my time, and until I pull that time I will just sacrifice the lesser important organs. So what happens when the blood supply is reduced to these organs? If the blood supply is reduced to kidneys, it leads to reduction in glomerular filtration rate, which eventually leads to decrease in the urine output. Now, what happens when the urine output of a fetus is reduced? The total amount of amniotic fluid reduces, and that leads to reduced AFI. What do we call reduced AFI? Oligohydramnios. So basically, chronic uteroplacental insufficiency, which is basically not enough blood that is coming to the placenta from the uterus, that leads to oligohydramnios. Whereas when the gut is going to be depleted of blood, what is the clinical significance of this? So whenever a baby is born which had fetal growth restriction because of this uteroplacental insufficiency, after they are born, their gut is kind of without any blood. The splanchnic circulation has reduced amount of blood. So if the baby feeds within the first 24 hours from the mother, then that food or that milk is going to go into the intestines, and the intestines, which will have no peristalsis because they were devoid of any blood supply, they will have accumulation, and that will accumulation of the milk, and that will lead to necrotizing enterocolitis and even perforation. I do not want this. Like what we do after delivery, these babies are kept nil by mouth, and they are supplemented with probiotics in an ideal setup, and with parenteral nutrition if required. For the first 2 to 3 days you don't give them anything orally. You wait until the body normalizes, the blood supply is restored back to the gut, and then you can start feeding them gradually. The liver, when the blood supply to the liver is reduced, what it does is it depletes the glycogen stores that are present. So the glycogen stores that are present in the liver are depleted. This leads to a reduction in the size of liver, or what I will also call as a liver span, is reduced. When the liver span or the size of liver reduces, automatically the abdominal circumference also reduces. This is what actually explains why the abdominal circumference is less than the head circumference in a baby with asymmetrical FGR. So coming back to the topic, what are the causes of asymmetrical FGR? Anything vascular that is leading to uteroplacental insufficiency. Basically whatever reduces the blood supply to the fetus is going to lead to that. So what are the causes? First of all, it is going to be preeclampsia, severe preeclampsia. So preeclampsia, basically uteroplacental insufficiency. What more? Any vascular disorder, vasculitis भी उसमें आता है, vascular disorders, vasculopathies, diabetic vasculopathy, Apla syndrome. So these are all the main reasons why asymmetrical IUGR will happen. Basically there is going to be a reduction in the blood supply to the fetus. इसमें मैंने diabetic mellitus का भी consideration ले लिया है. So this is your basic definition of fetal growth restriction. Now whenever a baby is delivered with me, I'm yet to start the case by the way. First of all, I'm just giving you a brief roundup of what fetal growth restriction is. So now whenever a baby is born to me with low birth weight, there are a few reasons that I will suspect. The first reason that I shall always suspect is going to be wrong dates. By wrong dates I intend to say, especially in women who had PCOS or PCOD, they had irregular cycles, or women who were consuming OC pills, they had varied cycles. So the women who were missing their pills and were getting irregular cycles, but mostly the obese women who had PCOS, they have irregular cycles. They get cycles once in 2 months or once in 3 months. So they don't really know when their last menstrual period was. And if they know it, it is kind of misleading. I mean, she must have had her last menstrual period 3 months ago, but she has conceived only in the last month. So basically वो पहले के जो 2 month का LMP है, that is wrong. But unfortunately, because we have calculated those 2 months as well, we get a larger gestation age than what the fetus actually is. For example, the fetus might be conceived just 14 days back, but her last menstrual period was 3 months back. So unfortunately मैंने उसका LMP लिया 90 days ago when the fetus was actually at 14 days. was just 14 days. So there's this huge gap that occurs, which is why wrong dates is one of the most important reasons why you can have a low birth weight. But the prevalence of wrong dates is very low, because now you have every female who has undergone at least one USG. So you confirm the fetal dates or the gestational age by USG. Now, given that almost every village as well, even the remotest of areas, have at least one center with a USG, it is very rare for a female to not come to us with at least one USG that has been done for her. So USG can more or less confirm for me that the dates were wrong. The next type is going to be the baby's weight is small. It is small for gestational age, but its mother, the baby's mother, was also small. The mother's herself weight is just 36 kgs. Her height is 4 feet 8 inches. So the mother is herself is small. The father of the boy, he also had a small stature. You often see these couples who are coming to us who both are very short in stature. So in this scenario, the baby is also going to have a genetic potential that is going to be keeping him always short. So this baby is going to be of low birth weight, but the baby will have nothing pathological in it. Also, once it is delivered, all these babies with fetal growth restriction because of uteroplacental insufficiency or these intrauterine infections, eventually if the cause of the insult is cleared out, if the TOJ infections are cleared, or after delivery when uteroplacental insufficiency doesn't exist, these babies will have a normal growth potential, and then they will cover up for the decreased fetal weight that they had at birth. But the ones with small for gestational age, because of constitutionally small stature, basically उनके मॉम डैड दोनों स्मॉल थे या फिर उनका जेनेटिक पोटेंशियली कम था, they will always say short. So basically you have those kids in your classroom who are of the short stature till their 10th standard, and they just don't increase in their height. So these are those people. They don't have anything pathological. They are all normal. It is just that their genetic potential was only limited to make them that tall or that big in weight. So constitutionally small. Basically, they have achieved their genetic potential. Their genetic potential was always normal, and there is nothing abnormal in them. Whereas the third ones are the ones who have fetal growth restriction. And our topic today concerns this thing. इसके नीचे आता है वो symmetric or asymmetric. So this is going to be what we are discussing today. So small for gestational age में आते हैं ये wrong dates, constitutionally small and fetal growth restriction, whereas the only pathological one is this. The other two are completely normal. N में लिखता हूँ ऐसे normal के लिए, whereas this one is abnormal. So today our discussion is going to pertain to this. So now whenever a female comes to me with any complaint of, or with just she comes to me an OPD visit and I diagnose her to be a female with fetal growth restriction, then in that scenario I have to admit her for monitoring. So when I admit her, how does my history begin? Now we are starting with the actual case discussion. So in that case discussion, the first thing that you'll be asking her is going to be her age. Now, what is so significant about her age? Now, it is well known that the extremes of age, and by extremes of age I intend to say at less than 18 years and at more than 35 years, there's an increased chance that this fetus will have fetal growth restriction. So now, first of all, I'm going to be talking about a few risk factors. So in risk factors, the first thing that I'm going to be considering is going to be her age. Now why at less than 18 years of age? At less than 18 years of age, the female herself, the body is malnourished. The female just had her menarche a couple of years ago, or maybe 4 to 5 years ago, and her body herself is malnourished. It is not adept enough to grow a fetus inside her. Her stature herself is very small. So this baby, because of malnourishment and immaturity of her organs, is going to have fetal growth restriction. After the age of 35 years though, there is an increased risk of aneuploidies. Now these aneuploidies are going to lead to, as I mentioned, symmetrical FGR. So now coming to the part of risk factors, what are the risk factors that you would be looking for in a female when you admit her, just to know what are the reasons why this growth restriction might have happened. So you have one, maternal risk factors, and then you have fetal risk factors, and then you also have placental risk factors. So talking about the maternal ones first, The first one that we have already discussed is going to be the age of that female, as we have already discussed. Apart from that, the pre-pregnancy BMI. So basically, a female who is malnourished, who has a BMI of less than 18. Now remember, I'm not saying pre-pregnancy weight. I'm not saying weight because Indian women can be of short stature. So if the stature is short, they are going to be low in weight. So I would rather look at the BMI, and if the BMI is less than 18, then I would know that this female is malnourished and she is having a poor nutrition status, which is why, because of her own poor nutrition status, the baby is small. Now you would ask me, poor nutrition status से anemia होगा. Does anemia lead to fetal growth restriction, or does it lead to fetal anemia? The answer is a big no. Q. The placenta contains something called as ferroportin. The same ferroportin that you have heard in the iron absorption process in your gut. Now this ferroportin, उसका एक ही काम है कि iron खींच के लेने का बॉडी में. Similarly, the placental ferroportin pulls all the maternal iron for the fetus, and it ensures that the fetus, literally like a parasite, is going to grow normally, and the fetus gets all the iron from the mother to itself. So basically, it ensures that the fetus is kept normal at the expense of the mother. So maternal anemia will never lead to fetal anemia. Remember that. Yes, the mother might have other nutrients, all the micro and macronutrients that are deficient in her, and those macro and micronutrient deficiency is going to reflect on the fetus, and then it is going to be low in weight. But fetal anemia does not occur. If there is fetal anemia that you can see on the Doppler, then you have to think of other causes that are immune and non-immune. We'll be coming to that discussion in yet another chapter on Rh negative pregnancy. So pre-pregnancy BMI is a high risk factor. It does contain as well maternal malnourishment. Apart from that, a reduced intake of food or a reduced pregnancy weight gain. Pregnancy weight gain कब कम होता है? When the female is not consuming anything, or she has some chronic illness like tuberculosis or some autoimmune disorder which is flared up. So if she is going to consume less of food, she gets less of nutrients, and that can be the reason why the baby is not going. So pregnancy weight gain, if it is less than optimal, it can also be less than optimal in a female who has preeclampsia. Apart from that, mothers with maternal high risk factors. So maternal medical comorbidities. मेडिकल कोमोबिडिटीज कौन सी होती है? प्री क्लैम्शिया होता है, या फिर क्रॉनिक हाइपरटेंशन बोलूँगा. डायबिटीज़ मेलाइटिस लॉन्ग स्टैंडिंग अगर है, सो बेसिकली ओवर डायबिटीज़ मेलाइटिस with vasculopathy. Vasculopathy कैसे रिफ्लेक्ट होगा? द फीमेल विल ऑल्सो हैव अदर वैस्कुलोपैथीज लाइक रेटिनोपैथी एंड नेफ्रोपैथी. सो वो बहुत इंपॉर्टेंट है. अपार्ट फ्रॉम दैट, क्रॉनिक रीनल डिजीज विच लीड्स टू, और CKD as we call it, chronic kidney disease, as it leads to global endothelial dysfunction. Apart from that, if she has any autoimmune disorder like Apla syndrome or SLE, any other thrombophilia. Why Apla syndrome? Basically, Apla syndrome is going to lead to antibodies that attack the endothelium and lead to clotting. This clotting will attack the spiral arterioles, and the blood supply to the fetus is going to be diminished. Apart from that, if the mother has any high risk factors for hypoxia. What hypoxia am I talking about over here? I'm talking about any chronic smoking, or if the mother, because of smoking, now has developed COPD. So anything that leads to chronic hypoxia in the fetus, or cyanotic heart disease like tetralogy of Fallot or transposition of great arteries. So cyanotic heart disease. ये हो गए all the maternal risk factors. What are the fetal risk factors? So the fetal risk factors first include, very important, सबसे important है multiple pregnancy, that is twins. And twins क्या हो सकता है कि the uterus may not have enough space for 2 babies and 2 placentas to be accommodated. So it ends up, ये हो गया DCDA twins में, when there are 2 placentas. So it might just end up कि one placenta is small and it is not adequate enough to provide the baby that it carries enough of nutrition, whereas the other placenta might be normal. The other way is दोनों एक दूसरे का खा रहे हैं and both have smaller placentas. The third one is in a case of मोनोकोरियनिक जेस्टेशन, जिसमें वो सब कॉम्प्लिकेशंस आते हैं, ऑल दोस ट्विन ट्विन ट्रांसमिशन सिंड्रोम, TAPS, ट्रैप सीक्वेंस, all these things. Apart from that, there can also be unequal placental sharing. So even if you have an entire placenta for two fetuses in monochorionic gestation, one placenta takes, let's say, 30% of the placenta, whereas the other one is taking 70% of the placental vasculature. So unequal placental sharing can be one of the reasons. So multiple pregnancy. Apart from that, congenital anomalies, very important. Third, chromosomal abnormalities that we have already spoken, like Down syndrome, Turner syndrome, so chromosomal aneuploidies. Torch infections. So these are all the major reasons. What in the placenta? In placenta, we can have things like chronic abruption, what we also call as the CAOS, that is chronic abruption oligohydramnios sequence. So क्या होता है? Assume in your first trimester you have something called as a subchorionic hematoma. Now subchorionic hematoma, if you extrapolate it to third trimester, it is something very similar to retroplacental clot that occurs in concealed abruptio placentae. So similarly, in first trimester there is a subchorionic hematoma. Now in that area, the blood vessels that were being supplying, that were being connecting the mother and the fetus, they have been destroyed. This destroyed area will never regrow its vessels. So whenever the placenta increases आगे जाके in second and third trimester, the fetus will also grow, but there will be that patch जहाँ पे वो blood accumulate हुआ था in subchorionic hematoma, जहाँ पे the vasculature never developed. We call this chronic abruption. This will eventually lead to reduced blood supply. Reduced blood supply से हमने already we have spoken कि kidneys का blood supply कम होता है, and that leads to oligohydramnios. Hence we call this chronic abruptio oligohydramnios sequence, CAOS. Apart from that, if there is single umbilical artery which is seen in cases of abnormalities, or placental infarcts that you see in patients with Apla syndrome. So these are all the important factors, circumvallate and circummarginate placenta. So these are all the high risk factors that in a patient can predispose to the risk of fetal growth restriction. So coming back to my history, in the history, my first part of history is going to be my demographics. Now I've always mentioned that there is a certain pattern in the demographics. There will be the age, there will be occupation. Then I prefer mentioning the LMP, बीच में parity status भी आएगा, the EDD, the gestational age. So these are all parts that I mention, or I prefer to mention, in the demographic history. That is followed by all the chief complaints. So in demographics, age, as I've already mentioned, that it can be one of the high risk factors. Apart from that, occupation can have some bearing on the socio-economic status. Socio-economic status, in the poor socio-economic strata, socio-economic status mein, if the female is from a poor background, then she will have poor access to good nutrition. Apart from that, she will be staying very close together, so there might be a higher risk of having tuberculosis. So tuberculosis is a chronic disease. Chronic disease से female को malnutrition होगा, she will have a lean stature, and she can have fetal growth restriction. So occupation and socio-economic strata are kind of connected to each other. Apart from that, if I'm talking about parity, multi-parity, especially with poor spacing of the pregnancies, if the pregnancies are spaced too close to each other, the interconception period is short, then a female's body doesn't get enough time for it to regrow or for it to become normal again. This will lead to an affected next pregnancy, wherein the female herself was not optimal nutritionally, and hence the baby bore the brunt of it. So poorly placed pregnancies, parity plays a big role. Increasing parity will always have an effect on fetal growth restriction. Apart from that, the LMP. LMP is important in cases of wrong dates. Also, in LMP, I have to ask her about her contraceptive history. वो तुम लोग पीछे भी पूछ, आगे जाके भी पूछ सकते हो in menstrual history, but ask if she was consuming OC pills at any point. Now, coming to chief complaints, I always say that there are 4 chief complaints that you have to ask in every female. What are they? Pain, bleeding per vaginum, leaking per vaginum, and decreased fetal movements. So in this, pain का क्या relation हो सकता है? Pain can be because of 2 things in this female. fetal growth restriction है मेरा case. So pain in abdomen can first of all be because of preterm labor. So preterm labor का risk बहुत है. Apart from that, fetal growth restriction if it is because of severe preeclampsia, then in that scenario she might have abruptio placentae. So always ask for this. Bleeding per vaginum, again abruptio placentae will have a role. Similarly, history of bleeding per vaginum in the first trimester will lead to a risk of chronic abruptio oligohydramnios sequence, as we have already spoken before. They do say that all the women who have had threatened abortion in the first trimester but the pregnancy continued, she didn't have complete abortion, the pregnancy continued, these women often end up having preterm birth as well as low birth weight baby. Leaking per vaginum, again not that likely, but leaking per vaginum we can connect it with preterm premature rupture of membranes due to polyhydramnios, and polyhydramnios that had occurred because of diabetes mellitus, or over diabetes mellitus mein you will have vasculopathy. So in that sense. And finally, decreased fetal movements or absent fetal movements can point towards the possibility of, first of all, hypoxia. The fetal movements decrease whenever there is hypoxia to the fetus. The autonomic nervous system also is going to be depressed. Apart from that, if there is an IUFD because of abruptio placentae or because of Doppler changes that had occurred, that will lead to decreased or absent fetal movements. So these are the 4 major complaints that I'm going to be asking for. Then I come towards specific complaints. Chief complaints के बाद में specific complaints. So right from the first trimester, first of all I will ask her if she had consumed any drug apart from the routine in the first trimester. I would ask her if she has consumed any drug. So what drug am I speaking about here? Any teratogenic drug if she was consuming, I will need to ask her about that. If she has inadvertently consumed, if she had some other comorbidity, if she had any other medical disease for which she was consuming any drug in the first trimester which she herself stopped later on because she understood that she is pregnant, but she has still consumed it for the first month or 2 until she knew that she was pregnant. So you have to ask her for the consumption of drugs apart from iron and folic acid which they anyway consume. Apart from that, in second trimester, for a second trimester female, second or third trimester, you would ask her for pre-monitory symptoms of preeclampsia: headache, diplopia, epigastric pain, blurring of vision. All these things you are going to be asking us of pre-monitor symptoms which will point towards preeclampsia leading to the fetal growth restriction. So all the specific complaints have to be asked. Third trimester में as well you would be asking her, and apart from that, bleeding per vaginum, all the chief complaints that we have already spoken. Menstrual history, I do not really focus much on it, but irregular periods in this topic is very important. So wrong dates की तरफ वो point करेगा. Fine. Then coming to her obstetric history. In obstetric history, I would want to know if her previous pregnancy also had a similar history of fetal growth restriction. So if there was a history of fetal growth restriction, I will also ask her if she had any medical comorbidities like preeclampsia, because then it is very likely that she will have it again in this pregnancy. What you will not ask her is any history of TORCH infection, because if she has already had TORCH infection in the past, then it is very likely that she is going to be immune, she is going to have IgG present in her. So in a previous pregnancy, history of TORCH infections, definitely not. Similarly, in patients in whom you are taking a case on recurrent pregnancy loss, you never ask them for TORCH infections, because infection तुम्हें बार बार नहीं होगा. You will be immune to it. You will have IgG that has developed in your body. So we'll ask that. Although you can ask about recurrent pregnancy loss to ask about APLA syndrome. So APLA syndrome can be one of the reasons why she is having recurrent pregnancy loss, but not TORCH infections. Fine. Then I would like to ask her about her past medical and surgical history, which will again have history of any chronic hypertension, long-standing uncontrolled diabetes mellitus, chronic kidney disease, or any other syndrome like APLA syndrome that she had diagnosed earlier. So any medical comorbidity. In past history, I'm also going to be asking her about all her addictions regarding smoking or drinking. Drinking fetal alcohol syndrome is going to lead to IUGR. Apart from that, smoking is going to lead to hypoxia. That hypoxia is again going to lead to fetal growth restriction. Fine. Family history, again the same points that I'm going to be asking. Now coming to the examination. Now all this history is going to give me a little idea about what might possibly be my diagnosis. But now coming to the examination, that will give me a better idea of how severe is the IUGR. So first of all, examination पे मैं उसका general condition देखूंगा, which is likely going to be fair. If she is afebrile or not. Afebrile, again, you would ask torch infections. Now torch infections often end up presenting in a very subclinical fashion. The mother might just say that she had some rash that she did not go to a doctor for because it resolved in a couple of days, or she just had a bout of, let's say, cold flu-like symptoms which she ignored. She said that it is my routine common cold that I get, but that probably was because of one of the torch infections that she had. So the maternal or the clinical appearance of these torch infections in the mother is very subclinical. It is something that often gets missed. So do not think कि torch infection कैसे हो febrile हो सकती है. She can be febrile because of something apart from that. She can be febrile along with having growth restriction, but do not correlate them without having a proper base of knowing the focus of that infection. Then coming to pulse and blood pressure. ब्लड प्रेशर अगेन प्री इक्लैम्शिया के रिस्क के लिए बहुत इंपॉर्टेंट है. ऑल्सो क्रॉनिक हाइपरटेंशन एंड क्रॉनिक रीनल डिजीज, दीज पेशेंट्स विल हैव likelihood of having fetal growth restriction. Apart from that, in general condition, you are also going to look at her BMI, that is pre-pregnancy BMI, her current weight, and her nutritional status. So if she is well built, moderately nourished, or poorly built, so nutrition status as well is going to be very important. And her build. Fine. Then proceeding with the obstetric abdominal examination. Before that, a few other points as well. I'm going to see if she has anemia, so if she has pallor, and if she has pedal edema. Pedal edema is going to be indicative of possibility of preeclampsia. नेक्स्ट कमिंग टू दी पर एब्डोमिनल एग्जामिनेशन. यहाँ पे एक CVSRS भी एग्जामिनेशन करना है कि अगर साइनोटिक हार्ट डिजीज़ है तो उसको मर्मर रह सकता है. नाउ कमिंग टू दी पर एब्डोमिनल एग्जामिनेशन, हर सिम्फाइजियो फंडल हाइट is going to be reduced, obvious सी बात है. So what is going to be the difference? So the difference between the period of gestation or the gestational age and my symphysial fundal height, SFH, if it is more than 4 weeks, then I call this fetal growth restriction. So more than 4 weeks is a very significant thing that I need to know. A little bit of a change, more than 2 weeks, whereas the fundal length or the fundal height, if it is more than 4 weeks, then I call it fetal growth restriction. Now what is the difference? The fundal height is seen by using the ulnar margin of your right hand, whereas the symphysial fundal height is seen using a measuring tape from the symphysial pubis to the fundal height that you had measured earlier. So फंडल हाइट जो तुम्हारा होता है, जो तुम लोग अपने हाथ से देखते हो, उसमें इफ देयर इज अ डिफरेंस ऑफ मोर देन 4, बिकॉज इट्स अ रफ मेथड, उसमें अ डिफरेंस ऑफ मोर देन 4 इज इंडिकेटिव ऑफ फीटल ग्रोथ रेस्ट्रिक्शन. इफ द डिफरेंस इज ऑफ 2, व्हेन यू आर मेजरिंग विद अ टेप, यू मेजर इट विद द इंच साइड फेसिंग you and then you overturn and then you see the centimeter side. If it is more than 2 weeks, then you call it fetal growth restriction. So that is how you define it. Apart from that, you will also want to check the fetal lie. It can so be the case that the baby is in transverse lie, and transverse lie होने की वजह से you are feeling the fundal height to be much lower. Now imagine if this are your 2 uteri. यहाँ पे दोनों में 3 kg का ही बेबी है, बट एक बेबी लॉन्जिट्यूडिनल है इसलिए उसका फंडल हेड नॉर्मल आ रहा है, और एक बेबी ट्रांसफर्स है और इसका वजह से उसका फंडल हेड आप देख रहे हो थोड़ा नीचे आ रहा है दूसरे से. यू माइट एंड अप कॉलिंग दिस टू बी फीटल ग्रोथ रेस्ट्रिक्शन बाय जस्ट डूइंग द fundal height. Do not do this mistake. Also do the other Leopold's maneuvers to look for the ends, the poles of the fetus. So always check for the fetal lie. Also after fetal lie, check whether the fetal parts are easily felt. If the fetal parts are too easily felt, then there is a risk that this baby might have oligohydramnios. Oligohydramnios अगर है, so fetal growth restriction तो लगेगा ही, but apart from that, oligohydramnios is also going to be indicative of chronic uteroplacental insufficiency, which is very likely because of preeclampsia. So very important. Apart from that, you're also going to be auscultating with your stethoscope to know whether the fetus is alive in first place or not. So over here you have your case ready, and in that case you have your basic chief complaints, your demographic history, your examination findings. On examination findings, if your जो right hand से तुम देखते हो तुम्हारा by standing on the right side of the patient, at that point of time when you see with your right hand, with the ulnar border of the left hand, when you are standing on the right side of the patient, with that ulnar border of left hand, when you are seeing it, at that point of time it has to be a difference of 4 or more than that. If the difference is more than 4, then you can be sure that there is a potential of fetal growth restriction. Apart from that, when you are taking it with using a tape, in that if the difference is 2 or more, then you call it fetal growth restriction. Now the next question that is going to be asked to you is going to be, how do you manage this patient? So management कैसे करोगे? So managing any fetus with fetal growth restriction, I have a few tests, or I have a few weapons, I would say, that I use to check. So what are those weapons? The first most important thing that I have is going to be my ultrasound. So when I talk of ultrasound, I have two ways. The first is going to be biometry, and the other one is going to be a Doppler. So when I talk of biometry, in that biometry I'm going to be measuring the abdominal circumference, the head circumference, the biparietal diameter, the fetal length. So all these diameters I'm going to be checking, and I'm going to be confirming whether the FGR is actually there. So fetal growth restriction by ultrasound is also when there is a lag of 4 weeks between the ultrasound findings and the actual gestational age through LMP. So that is how first of all मैं ultrasound करा के confirm करना चाहूँगा whether this baby has fetal growth restriction. Once I am done confirming this fetal growth restriction, then I will be going on to Doppler. Now Doppler is basically me checking the flow of the blood supply in a few vessels. Which are those vessels? सबसे important है umbilical artery. The next important is your middle cerebral artery. The third is your uterine artery, and the fourth important is your ductus venosus. Now umbilical artery. Now basis of umbilical artery, you have your umbilical cord. उसमें you have two arteries and one vessel. So two arteries and one vein. Now this artery is responsible for taking away deoxygenated blood from the fetus to the placenta, whereas the vein carries the oxygenated blood from the placenta to the fetus. So यहाँ पे I shall be checking the flow in this umbilical artery, because umbilical artery में जो blood जा रहा है, the force of that blood is going to be because of the pumping of the fetal heart. Now in a normal baby, you need to know that during the systole and diastole, both you will have, in a normal fetus you will have blood flow in the systole as well as during the diastole. Basically at all times, during all times of the cardiac cycle, you are going to have blood supply during systole as well as during the diastole. Whereas in a fetus that is affected with uteroplacental insufficiency, there are going to be a few changes. First of all, what starts happening is the diastolic blood flow decreases a bit. The systolic blood flow is still going on, but there is going to be a reduction in the end diastolic flow. So this is what we call as reduced end diastolic flow. This is the first stage wherein we can gauge, or wherein we will know that there is a reduction in the blood flow in the umbilical artery. This is followed by absent end diastolic flow in the diastole. So the systolic flow still continues because the heart is actively pumping, but during the diastole there is going to be complete absence of flow. Whereas the last stage is going to be reversal of end diastolic flow, wherein the fetus will instead be giving the blood back to the mother rather than taking the blood from the mother. So this is completely pathological. Now how does it define our management? For someone with reduced end diastolic flow, for someone who's normal, I would terminate this pregnancy at 40 weeks of gestation. Whereas for someone who has a reduced end diastolic flow, I would want to terminate it anywhere between 37 to 39 weeks of gestation. How do I determine that? I check the effective fetal weight. If the effective fetal weight is at less than 3 centile, then I terminate it at 37 weeks. If it is between 3 to 10 centile, then I terminate it at 39 weeks of gestation. If there is absent end diastolic flow, then I'll be terminating it at 34 weeks of gestation, and if there is reversal, then I terminate it at 32 weeks of gestation. Obviously, these two need steroid cover before termination, and the termination for both of these is going to be by lower segment cesarean section, whereas these can be delivered by vaginal route. Fine. So this is about umbilical artery. What about the middle cerebral artery? Now, middle cerebral artery is very important to know about the brain sparing effect that we had spoken. Now, what was the brain sparing effect? It is basically the blood is being preferentially given to the brain in comparison to the other organs. So how do you make that happen? So you increase the diameter of the cerebral vessels. So when you increase the diameter, your resistance goes down. Once your resistance goes down, your flow of blood through it increases. So a very simple thing that happens is the diameter of middle cerebral artery is going to be increased, and that diameter will reflect in reduced MCA resistance. Resistance is measured by two indices. One is resistivity index or pulsatility index. Just the way of calculating it is different, but both are resistance indices. So there is going to be reduction in the middle cerebral artery PI. So basically there is an increase in the diameter which is reflected by reduced MCA PI. So when this MCA pulsatility index reduces by 5th centile, 6th percentile, 5th percentile, that is when we say that there is brain sparing effect that has occurred. This brain sparing effect is an indication that I have to terminate this pregnancy anywhere between 36 to 37 weeks of gestation. So this is what is the importance of middle cerebral artery. Uterine artery, very important. Uterine artery has a role in the first trimester between 11 to 14 weeks. Now a few basics. This is your uterus and this is your spiral arterioles that are coming over here. In a normal pregnancy, what happens during 12 to 16 weeks, यहाँ पे जो ट्रोफोब्लास्ट होते हैं, these trophoblasts go and occupy your spiral vessels, and their diameter from being इतना is turned into ज़्यादा. This is what we call as endothelium to epithelium transformation. So basically the endothelium is replaced by the epithelium. How does that happen? The tunica intima and the tunica media is destroyed completely by these trophoblasts. These trophoblasts, which are epithelial cells, they destroy it. This leads to only one layer of the vessel remaining, and that is going to be your tunica adventitia. When this tunica adventitia remains and the other two layers are destroyed, obviously the diameter increases and the blood flow coming in also increases so as to support the growing fetus. Now this doesn't happen in preeclampsia. These trophoblasts don't invade. So the vessel which was itna stays utna hi, and the diameter doesn't change, and this leads to fetal growth restriction. Now how will this be seen as? Now these vessels, these spiral arterioles were coming from uterine artery. So whenever the diameter of these fetal vessels would decrease, the resistance index of uterine artery or uterine artery PI would also reduce, because the resistance was reducing and the diameter was increasing. But in preeclampsia this doesn't happen, which is why the uterine artery PI stays increased. Which is why in first trimester an increase in the uterine artery PI is an indicator of poor trophoblastic invasion, and that is a predictor of preeclampsia and fetal growth restriction that will eventually occur in the third trimester. So uterine artery PI का ये significance है. In the first trimester, a few people even check it at 22 weeks of gestation. Once you see this happening, you have to start these patients on aspirin in low dose. Low dose aspirin is between 60 milligram to 150 milligram. A lot of people started at 75, a lot of started at 150. You can start any of these. Once you start this, the diameter and the clotting is reduced. It increases or it maintains कि जितना भी diameter हो at least blood जाता रहेगा ठीक से. Lastly, you have your ductus venosus. So ductus venosus is one of the last vessels in which the blood supply is going to be completely deranged. So whenever a fetus has reversal of end diastolic flow in umbilical artery, उसके बाद में you have to check the ductus venosus. If there is a reversal in ductus venosus as well, then the baby is about to die within the next hour or so. You have to immediately terminate and you do not wait for steroid cover. So ductus venosus will guide you whether you can wait for completion of corticosteroid cover or you have to terminate it immediately at that moment itself. So this was your first very important marker that you can use for diagnosing and managing fetal growth restriction. Your next is going to be ये हो गया तुम्हारा asymmetrical FGR manage करने के लिए. If the ultrasound is coming to be normal, then I have to go ahead and check the second one, and that is going to be my torch profile. Torch profile में आता है IgM and आता है IgG. This is all maternal, mother का check कर रहे हैं हम. If the IgM is positive, then the mother has had an acute active infection. Whereas if the IgG was positive, then the mother had a remote Purana infection. But what if IgM भी positive आता है and IgG भी positive आता है? In that scenario, I do a test called as IgG avidity. Or if the IgM was negative but the ultrasound was showing signs of torch infection, then I do IgG avidity. Avidity in simple sense means affection. How strong is the bonding between the torch infection and the antibodies? So as time increases, since the infection, the affection is also going to increase. The affection increases, the avidity increases. So a high avidity shows a very old infection, whereas a low avidity shows that the affection is still not that much and the strength of binding between the antigen and antibody is not that developed. So it shows an infection in the last 3 to 5 months. अगर IgM पॉजिटिव है तो मतलब है कि इसमें लास्ट 1 to 2 months में आया है वो पेशेंट पॉजिटिव. So this is for the mother. Once the mother is turned to be positive, if we know that the mother has a risk, then we go ahead and we do amniocentesis एंड उसका हम करते हैं टॉर्च बेबी का PCR. सो बेसिकली डायरेक्टली टॉर्च पॉलीमरेज चेन रिएक्शन करेंगे ऑफ द फीटल सेल्स दैट आर बेसिकली द एमनियोसाइट्स एंड यू वुड नो वेदर द इंट्रायूटराइन फ्लूइड इज एज वेल अफेक्टेड बाय द torch infection. It might so happen that the mother was infected but it didn't go to the fetus. So to confirm whether it has affected the fetus, you do a torch PCR of the amniotic fluid. What is the treatment? You give spiramycin, you can also give pyrimethamine and sulfadiazine, and that is the treatment for torch. Although unfortunately it is often too late by the time you diagnose it. Lastly, if all of these are negative, how do you check for it? In first trimester, you always do to prevent dual markers, and along with dual marker you also do an NT-NB scan. So in dual marker, which are the two tests that you do? You check for beta HCG and you check for PAP-A, that is pregnancy associated plasma protein A. So in that scenario, you are going to be checking for these two markers. Now remember that we call a combination of these two tests that we do between the 11th and 14th week as the combined screening. Don't forget that the word that I'm using over here is screening. It is not combined testing, it is combined screening. So once the screening comes out to be positive, I have to do chorionic villus sampling or amniocentesis to be sure that this is a screening test and that the gold standard test is always going to be amniocentesis or CVS. So in dual marker, I have serum beta HCG and PAP-A. Whereas NT-NB scan में I check for the nucal translucency and nasal bone. Nasal bone to is for trisomy 21. If it is absent, then you know that the baby possibly has Down syndrome. And what about nucal translucency? Now nucal translucency का concept बहुत आसान है. Now if this is your fetus, if these are your hands and these are your feet, These are your eyes over here, and this is your nose, mouth. So basically, this is your nuchal or the neck region over here. Now, this is more or less the dependent part of the fetus. So when you check, first of all, you have to calculate the crown rump length. If the crown rump length is between 45 to 84 or 85 millimeters, then this patient is a candidate for checking for nuchal translucency. Now, if this fetus, assuming has some kidney disorder or has some cardiac disorder, then there is going to be changes of congestive heart failure, and the baby is going to have what adults में अगर ये होता तो क्या होता, that the adult would have had congestive heart failure, pedal edema, dependent part edema, ascites, pericardial effusion होता. So in this baby, because the dependent part is the nuchal region, यहाँ पे edema होगा. That edema increases the translucency of the neck region, which is why the nuchal translucency increases. It is an indicator of some congenital anomaly that the baby has, which is leading to edema of this dependent part of the fetus. So when the NT is more than 3 millimeters, the screening is said to be positive, and you do a gold standard test. And that gold standard test is amniocentesis or chorionic villus sampling, and then उसके साथ you will do a fish, which will give you a report in 2 to 3 days, or a karyotyping, which will give you a better report but will take 8 to 10 days. So fish, that is for fluorescent immuno size hybridization, and fluorescent in situ hybridization, and karyotyping, which will check for all your chromosomes. That has to be done for that amniotic fluid. This will give you a diagnosis whether the baby has any congenital abnormality. If you do not manage to do your dual marker, then in the second trimester you can do quadruple markers. In quadruple markers, you again have beta HCG, then you have inhibin A. How do you remember it? Remember, this is the first marker that you test in your body, in your life, which is going to be A. A is the first alphabet. Whereas when you grow up, when you become pubertal, tab your ovaries start secreting inhibin B along with estrogen. Apart from that, you will also be checking for alpha fetoprotein and unconjugated estriol. Now, beta HCG is going to be increased in a fetus with Down syndrome. अल्फा फीटोप्रोटीन इज इक्विवेलेंट टू एडल्ट में जो एल्बुमिन का काम करता है. सो इफ अल्फा फीटोप्रोटीन reduces, it is indicative of some abnormality. If it increases, then it is equivalent to there is some leak in the body of the fetus. वो leak कहाँ रह सकता है? Most likely either the gut is outside or there is some open communication with the neural tube. So neural tube defects and intestinal defects में अल्फा फीटोप्रोटीन बढ़ेगा. Whereas unconjugated estriol, when it is reduced, then it is indicative of some problem in the fetus. So reduced unconjugated estriol, reduced inhibin A, increased alpha fetoprotein or even decreased, and increasing beta HCG are all markers of any of the congenital abnormalities that are setting in. Along with this, you will also do a TIFA or a level 2 scan, that is targeted imaging for fetal anomalies to look for congenital anomalies. Once you are done all this, at the end of it, if you still don't have any diagnosis, then you should know that 40% of the fetal growth restriction cases are idiopathic. There is not going to be any diagnosis. So that is it about all these cases. I hope this discussion has helped you and you will be able to answer the questions on this case much easily in the exam. If you have any doubt, please comment in the comment section below. I would be more than glad to answer all your queries. We have a discussion on antepartum hemorrhage coming up in the next 2 days, so do watch out for that as well. Until then, this is Dr. Aditya signing off.